Good morning, good afternoon to you all.
Good
Good
afternoon,
afternoon,
sir.
sir.
Hope you are doing well.
Good afternoon, sir.
Please.
Yes,
By God's grace.
we thank God. Welcome back to today's lecture.
Thank
We
you.
thank you. We started with fluid and electrolyte balance. We've done with the fluids, we've done with the electrolytes, and we are doing infusing therapy. Infusing therapy. We started this last week. We got to heparin and saline locks. Heparin and saline locks. We discussed the importance and then the purposes of intravenous infusions or infusion therapy. And today we want to look at heparin and saline locks. Those that you have seen on the ward, especially when patients are to receive intermittent infusions, and you see that he has to receive, for example, Cipro infusion and flagyl infusions, morning and evening, and you give the morning one. What do you do to the cannula? What do you do to the cannula which is in situ? We normally spigot it. And when we spigot it, what are the importance? Do we connect it with another infusion to maintain the line, or we put syringe with normal saline inside? If we do that, what are we trying to do? So today we want to look at the implications of spigoting or locking the cannula, so you can continue another infusions or another medication when the need arise, without necessarily continuously infusing the person. So that is what we want to do. So the program is used by hospital staff to maintain access to a vein where repeated dose of an intravenous drug may be required. For example, I've given you are receiving Cipro infusion, you are receiving metronidazole infusion, and you are going to repeat it BD for 48 hours. So these are example of repeated doses of intravenous medication. So the line must be maintained patent. But we cannot afford to puncture every time when we want to give this medication, set another separate line, inflict unnecessary pain on the patient. So we need to maintain the line, and therefore we need to spigot or lock the intravenous therapy or line or access. So the locks, or these patients may not need an intravenous line for the continuous infusion of fluids. The patient condition probably is a respiratory infection, pneumonia, and may not need continuous infusion. The chest is not clear. So the patient just needs the medication through the vein. So you may put a normal saline on to maintain the line, but at the blind side of you, the patient might raise the drop rate, and before you realize, the infusion is finished, and this can go and complicate the chest. So the patient may not need an intravenous line for continuous infusion of the fluids. The lots consist of a plastic cannula that has been filled with heparin or saline. So normally on the ward, we don't have the plastic cannula filled with heparin or saline, but we normally use or improvise with syringe. After the infusion or the medication is given, we fill the syringe halfway, and we put the syringe to fit tightly to the cannula, and we plaster it to maintain in position. This is what we normally do as an improvised locks. It can be saline, it can also be heparin. So we are here, we are discussing or describing the original lock. It is made of plastic cannula filled with heparin or saline, and a short length tubing, a short length of 2 to 3 inches, and it terminates in an airtight injection port. So it's just like there is a tight air at the tip of the tube where you will inflate, or where you push to push the medication through. The heparin or the saline prevents clotting at the IV site. So that is the essence or the importance of the heparin or the saline in the syringe that you put at the entrance of the catheter or the cannula. So you fix the syringe, but fill it halfway with either saline or heparin. And this is to prevent clot formation at the entrance of the cannula. So when the next time you are about to give the medication, the clot will not stop or will not prevent you from giving it. And the patient may be or may not be at risk of embolism from the clot. So the locks provide several advantages. Let us look at those advantages. So when you lock the infusion or the line, the risk of fluid overload is eliminated. So because there's no continuous infusion, and then the patient cannot even inflate it at the blind side of you because you have taken the infusion off. So the risk of fluid overload is eliminated because fluid is not continuously infused. This is clear. The chance of electrolyte imbalance is also minimized. Once you over infuse with the patient or fluid with the patient, there's likely going to be fluid overload and electrolyte imbalance. So once you prevent fluid overload, you also prevent electrolyte imbalance, or you minimize it. Greater freedom of movement allows the patient performance of normal daily activity. The patient can move around with that small thing fixed at the entrance of the cannula. The patient is free to move everywhere, and do whatever the patient wants to do without restricting him or her to lie on the bed. For the sake of IV medication, the patient is lying on the bed from morning till evening. The patient can be free to move about and do his or her normal daily activities on the ward. The patient can even go and come back to receive it. The patient is spared the discomfort of having a separate venipuncture each time a dose of the medication is required. So the patient is not exposed to pain while you have to inflict unnecessary pain and puncture the patient anytime you want to give IV medication. A separate line should be given. This pain is avoided if you give the lock to the cannula. Intravenous fluids. Once the prescribed intravenous fluid is selected by the sending institution medical staff, the IV tubing should be inspected to confirm there are no air bubbles, and the container should be inspected for cracks or tears or foreign matter, cloudiness, precipitation, or any other sign of contamination. Once you have your infusion bag with the fluid inside and the giving set, here we call the giving set IV tubing. So once you hear IV tubing, we are talking about the giving set. The names keeps on changing from country to country. So the IV tubing stands for the giving set. And then we have the infusion bag. You inspect. When you connect, you hang the infusion bag and you connect the giving set. You inspect the giving set and you also inspect the bag with the fluids. What are you looking for? When you connect in the giving set, you are looking for air or bubbles, cracks, tears. Has any part of the bag torn? Do we see any cracks anywhere? It means foreign matter has gotten in. Bacteria has been entered. It's infected. You cannot infuse it. Foreign matter, the color has changed to become cloudy. Don't put it on and tell us that the hospital will lose. Is that your money? Throw it away. If it goes inside the patient, you are going to kill this patient because it's going straight to circulatory system. Precipitation and any other sign of contamination. If you see any other sign of contamination, don't use it. Discard it, ignore it, and protect our patients. Should any of this become apparent, the fluid must not be used, The fluid must not have reached its expiry date. Very important. Sometimes you tend to tell us that after 3 months of expiry date, it is safe to use. After 6, please. This is going into somebody's circulatory system. Let us protect the patient. Could be your uncle, could be your brother, could be your daughter, could be your son, elsewhere, not in front of you. If somebody does that to him or her, you will not be happy. Don't let us kowtow to these demands from the administrators. We are looking for maximizing profit, but we are looking at the health and the quality of care we want to render to our patients. They can do their business, but we are looking for quality of care. That is what we stand for. When you are looking for expiry date on an infusion bag, please just look at it. It is printed on the fluid container. Sometimes at the top or at the bottom part, it is there. So you can go and look for it. If it is close to expiry date or is due, don't use it. Most of the infusion that we use on the wards, we have the normal saline, which is 0.9% sodium chloride in water. We have the Ringer's lactate or the lactate Ringer's, which is sodium chloride, potassium, calcium, and lactate. These are the composition of the Ringer's lactate infusion. Then we have the dextrose 5% in water, which is 5 grams of dextrose per 100 ml of water. We have solutions available in the volumes of, we have 50% bolus, 50 ml of bolus, 100 ml, 250, 500, 1,000 ml back. These are in different boluses or volumes. We have 10% dextrose, 5% dextrose, we have 15, sometimes 20, sometimes 50% dextrose. And they are used in a various management of various conditions. So they are sealed in an airtight plastic wrap to prevent contamination. If it is cracked, broken, torn, don't use it. Potassium chloride, thiamine, and multivitamin. We can also sometimes, on the wards, try to balance the nutrition the patient takes if the patient is unconscious. And every nutrition the patient takes is through parenteral. Then sometimes you will be tempted to infuse infusion that contain multivitamin to balance with the dextrose. So the patient will not be avitaminosis or will not be vitamin deficient. So we tend to call on some of these micronutrients and multivitamin infusions, such as potassium chloride, thiamine, and multivitamins. The thiamine contains the B complexes, and the multivitamins will supply the proteins, the plasma proteins that you need to maintain the osmotic pressure of the blood. Frequently stable patients are transported after the said institution has added potassium chloride to the IV solution. The potassium chloride is usually intended to replace the lost potassium due to vomiting. If the patient is vomiting, severe vomiting and having severe diarrhea, then you know the element that the patient is losing. So you'll be tempted to put in potassium chloride to maintain the ions that is being lost through vomiting and diarrhea. Or sometimes excessive urination through diuresis. This patient is losing potassium, and hypokalemia has a consequence on the myocardium. It causes arrhythmias. So why not infuse or have a solution that contains potassium and chloride to replace the lost elements? Frequently, postnatal patients are transported after the same institution has added thiamine. Sometimes, depending upon what the patient needs, you put the infusion and you add thiamine, which contains the B complexes, the multivitamin to provide the micronutrients such as the plasma proteins to the infusion. These are intended to correct vitamin deficiencies. Monitoring of the infusion site is required because in the event the IV becomes interstitial, so a free and necro from now going, don't say that the patient infusion, the patient hand is swollen. No, you have come to a BSc program, be more technical, be more professional. The infusion, the patient infusion has become interstitial, meaning it has moved from the vein and it has now gotten into the interstitial space. So the needle or the cannula, normally the cannula will be there, but the needle most of the time move out of the vein and enter into the interstitial space. So the patient vein has become, or the meaning that the juice is now going into the interstitial space instead of the vein. So in the event the IV becomes interstitial, which is moving, it has moved from the vein to the interstitial space, the potassium chloride or vitamin may corrode soft tissues in the area. So if you have potassium chloride or vitamins, the tissues may be corroded or may be irritated, and the patient may be having some discomfort around the area. But if the infusion is a normal saline, because the normal saline is fluids, the patient will not feel any distress, except that the infusion is so much and the pressure is causing the pain when it's putting pressure on some nearby nerves. Intravenous tubing. So I've told you that the intravenous tubing is called the given set here in our local dialect, but the name is intravenous tubing. If you go to the world right now and you talk about intravenous tubing, everybody will be looking at you. What is intravenous tubing? We call it given set. That is Ghana. That is where how we mention our terms. So you move away from Ghana to UK, any other place, they will tell you to bring the intravenous tubing. Then you'll be turning like a cockroach. Okay. The intravenous tubing may be a micro drip set solution administration that delivers 10 or 15 drops per minute. So the one that is big or bigger on the walls that we see all the time is the macro drip set that delivers 10, sometimes come in 10 drops per mil, others come in 15 drops per mil. Then we have another type called micro drip set of the burette type, and that delivers 60 drops per mil. It is very, very small. So when it delivers 60 drops per mil, it's not even up to 1 drop with the micro drip set. So the macro drip set will deliver 10 or 15 drops per mil, but it cannot be equated to when you are dealing with the micro drip set. It is used at the pediatric wards. If you go to the States, look at the infusion. It is not as big as the one we use on the general ward. When the tip is like a shiny metal, sometimes very, very small, and that delivers smaller quantities of fluids into these neonates, so they don't experience fluid overload. So the micro drip sets are used for routine infusions. As I've said, the MA type, the micro MA, the bigger ones always seen on the ward is used for routine infusions, whilst the micro drip sets are used for So while the micro drip sets are used in pediatrics and neonatal care, and when relatively small amount of infusions are to be administered over a long period of time, as noted earlier, pediatrics and neonatal IV care is beyond the scope of. So we are not dealing with pediatric and neonatal care, intensive care patients. So we are not going there. We are dealing with adult IV therapy. So we will not go to the micro drip sets. We are dealing with the macro drips, the bigger one. The infusion tubing drip chamber. So we know the infusion tubing drip chamber, the one that you press to fill. Tell them if they connect and they don't mute themselves, we can't allow them to confuse us all the time, right? So tell them, I'll be muting them, but how can I stop teaching and be muting you all the time? This, you should abide by it. Once you connect, mute yourself. So the background noise do not come into and cause disruptions here and there. Once you join, mute your microphone. This instruction should be clear. The infusion tubing drip chamber will achieve maximum flow rate when suspended approximately 3 feet above the site of injection due to the force of gravity. The greater the height, the greater the force of the force of flow due to the weight of the fluid volume. So here it's talking about when you set the line and you use the drip stance to raise the infusion bag. If the infusion bag goes higher, the higher it goes, the greater the force of flow. If the infusion bag is lower, the force of flow will be very, very low. But so if sometimes you set a line and it's not dripping out, you want it, check the height of the infusion bag. If it is too short, it will not flow well. Sometimes at least 3 feet above the site of the cannula is okay. But if you want it to flow very, very well, raise the drip stance. Once you raise the drip stance, the force of gravity will act on it and then increase the flow rate. Sometimes another factor can affect the flow rate. We'll talk about factors affecting flow rate, and that is the weight of the fluid in the container. When the fluid in the container is small, the flow rate is high. When it's about to finish, sometimes the flow rate is affected. It doesn't want to flow. You have to probably sometimes force it. So once the infusion in the container is more or is full, the flow rate, because of the weight, it will press on it and the force of gravity will push it and the flow rate will increase. As it's about to finish, then the flow rate will be affected. It will not flow as we want it to flow. Let us look at the tapes. The tapes that we use, that you people call it plaster. So they call it tape. Sometimes it comes in 1.5 inch adhesive. Silk or proper type should be used to anchor the needle or cannula to the skin. Some people react to the adhesives or the plaster, others don't. If the person reacts to the plaster, use the paper type to anchor the cannula to the skin. And the nurses know how to tear the plaster and apply it to the skin. If the physician or the in charge struggles to get the line and the nurse is apply the plaster and you destroy the line, the way they will shout on you. So you have to learn how to apply it. This is a skill, apprenticeship. You need to go to the world and learn them. The tape should be placed in such a manner as to prevent any movement of the device. That is why I said learn how to apply the adhesive or the plaster. And the application term is called crisscrossing. Crisscrossing. Sometimes they will tear the middle of the plaster small, not fully, halfway, and fix it to hold the cannula. Sometimes they will plaster it and then turn the plaster up, the adhesive side up, fix it under the cannula, and do the crisscrossing. No matter how you do it, provided it holds the cannula in position. There are so many ways of killing the cat. The tape at the needle hub or wing taping are effective methods of securing the device. So it is very good, it is very, very important to apply it well to hold the cannula in place. It is advisable to avoid placing the tape over the venipuncture site, making it difficult to carry out IV site care. Some people will apply so many plasters. Even when something is happening at the site you cannot see, please, maximum should be at 3 plasters. 3. or those on the ward, how many plasters do you need to secure a cannula? Yes. How many plasters? How many pieces do you need?
So we always use two.
Two. Fantastic. Two.
Sometimes one. They fix them on one.
Times one. Yes. Sometimes you tear the middle more than Papa pulls it. That's all. So some people they will not even, yes. Sometimes they will give three, others two, others one. Sometimes they will tear it more than half, 1.5 inch. They will go about 3 inches, 4 inches, very, very broad, and cover the site. When swelling is occurring, you cannot see to intervene. When something is happening, you cannot see. It should be very, very slim, 1/2 inch. That is it. If you travel outside, the rules are there. Additional taping is necessary to secure the arm or the hand board. So if you use a board, then you have to apply more plaster to secure the hand and the board. To secure a loop of tubing and to secure a loop of tubing and to secure the site dressing, 1 inch tape is recommended. 1 inch, 1 inch tape is recommended for this purpose. Use caution in taping in order to prevent nerve damage to the limb or circulatory impairment caused by excessive pressure. So once you are applying the adhesive, be sure, don't be too tight to obstruct circulation and also to destroy some nerves there and cause unnecessary tightness to the patient, create discomfort. There's a history at Comfort, not those who are there. You know, you've heard that some times ago when a nurse was trying to get a line for a patient, she used the tourniquet, tied it, struggled, got the line all right, plastered the cannula, the infusion was running up to some time. The child was crying bitterly, but the nurse forgot to remove the tourniquet. So the child was crying because the cloth has covered the tourniquet. Before they realized that the tourniquet was not removed, the hand has become gangrenous, and the child arm led to amputation of the arm. The child got amputated because of negligence. So be careful. Now, patients know their right. If you do anything and is somebody hands up? Yes. Stephen, your hand is up.
Hello, sir.
Yes.
What I've observed at ward is after setting the cannula, the cannula can remain more than 1 week. I don't know whether we have specific time to change cannula.
Specific
Hello,
time
sir.
to change cannula. When
Yes,
it
sir.
becomes dirty, you need to change it. Sometimes you yourself see that it is dirty. Once it is dirty, you have, okay. I think the line dropped. The network was bad, so the line dropped. So I've come back. I hope you can hear me.
Yes, sir.
Yes, sir.
Very good. All right, so let's continue. So this is the bag. If you look at the diagram there, this is the bag, and that is the giving set connected to it. That is the needle tip. These sides are there, the regulator, and where you close. If you want to pass medication, you click it and pass medication. So that is a complete bag, as you see there. Now, the flow rate. In order to ensure therapeutic effectiveness of intravenous fluid or fluids flashing into the patient's circulatory system, maintenance of a constant even flow is necessary. There are several factors that may alter or affect the flow rate. So here we want to look at what factors affect the flow rate. If the doctor gives me 5 liters of normal saline, or for example, 2 liters of normal saline, 3 liters of Ringer's lactate, to run these infusions over 24 hours, how do I ensure that my flow rate is going to maintain? How do I ensure that? So, factors affecting the flow rate. Naomi Bedu, Naomi, Salome, why? So one factor that affects the flow rate is venous pressure or patient positioning. Sometimes you have the line, the canal is inside the vein, but the patient's position prevents the blood from moving up. So you see that you connect the infusion and it's not flowing. But you see the cannula is inside the vein. Check the venous pressure, check the patient positioning. Infusion treatment drip chamber may not be 3 feet above injection site, thereby reducing the flow. I've told you the flow rate, if it's not 3 feet above the injection site, will not flow well. So check the flow rate or the height of the infusion bag and check the patient positioning. Vein spasms. Sometimes when you are infusing a very cold fluids, it causes the veins and set the veins into spasms. And once the vein set into spasms, it closes the lumen of the vein and thereby reducing the infusion that enters the circulatory system. Irritating or chilled fluids may cause a reflex action, which causes the veins to go into spasms at or near the infusion site. So that is what reducing the lumen of the infusion and therefore thereby reducing the flow rate. Development of phlebitis or thrombi. Phlebitis and thrombi can occur, especially during repeated infusions. So that is inflammation of the vein is the phlebitis. And when you develop a thrombi, maybe a clot has been developed there, and that can lead to thrombophlebitis. So we have thrombophlebitis and phlebothrombosis. The two are not the same. The thrombophlebitis is having a clot lodged around the part of a vein, and the clots, the body sees it as a foreign. So the clot starts releasing certain inflammatory response, serotonin, kinase, and these chemicals attack the vein area where the clot is lodged, and that area starts developing inflammatory response. Once a clot has led to the inflammation, it is called thrombophlebitis. But on the other hand, some veins may not be that healthy, and the vein may be inflamed, and that the inflammation of the vein may slow down some movement of the blood, and some blood may become sluggish, leading to clot formation. So that is called phlebothrombosis. So we have phlebothrombosis and thrombophlebitis, which is not the same. So always look at what is really causing the other to occur. Thrombophlebitis and phlebothrombosis. This may be caused by initial decrease in flow rate due to spasms or the pressure of the needle in the vein. As the clot forms, a substance called serotonin is released, which causes smooth muscle in the vein to contract more and start causing inflammation. viscosity and specific gravity of fluids. When you are infusing a very thick fluid, it doesn't move as you want it. Even on the ward, when you are transfusing a packed cell, it goes very, very slowly, because you have taken the plasma away and you are transfusing packed cells. So you don't expect the specific gravity and the viscosity is not the same as when you have plasma as a component of the blood. So you have increased the viscosity. So high concentration of dextrose and other infusions or transfusion blood tend to flow at a slower rate. But when you are infusing, for example, normal saline, the infusion is almost the same as the body fluids. It can run without necessarily getting any problem from the patient. But once you are transfusing a very viscous fluid, it slows down the flow rate. So it's a factor that affects the flow rate. Amount of fluid in the container. I've talked about amount of fluid in the container. The higher the fluid in the container, the greater the flow rate. The lesser the fluid in the container, the lesser the flow rate, and vice versa. Because the weight exerts pressure on the fluid and it flows high. Height of the fluid container. Talk about that. If you want the fluid to flow at least 3 feet above the needle site or the cannula site, 3 feet. If you want it to flow fast, you move the drip stand higher and it will flow fast. The tubing occlusion. It may be kinked, the given set may be kinked or may be bent, or the patient may even be lying on it. Bed accessory may be putting pressure on it, especially if you go to C2, the orthopedic wards, where they are having these traction kits and other gadgets. It may be having a direct pressure on the given set, and this may stop the infusion to flow. May become pain due to bending or being caught in under patient equipment in the patient. Occurs when airtight clot. Sometimes you have air clot going in there to block the flow. So you have to remove the air. Once it enters the patient, that's the end. Once you allow the air to enter the patient, that's the end. You can't remove it again. So be careful. Needle or cannula gauge and diameter. Last week, I explained that the gauge and the diameter, sometimes they are not the same, they are opposite. The higher the gauge, the smaller the diameter. The smaller the gauge, the higher the diameter. That's how it goes. So the smaller the needle or the cannula, the lower the flow rate will be. So even on the ward, when you are infusing a pediatric or a smaller child, you pick small cannulas. You pick small cannulas. And I wanted to get some cannulas, but I sent somebody on the ward to give me one. I think if you have it, those who are listening to me on the ward, you can help. If you have them around, just provide them the various types so we can see you. Just put your video on. So the smallest one is the which color?
Yellow.
Move. Purple. Move.
So I have
the smallest one is the purple.
Purple, fantastic. We have the purple color. So what I have here is the yellow and then the pink, but we have the purple, right? You have the purple, which is the smallest, and it goes like that. We have the blue, we have the green, we have the ash. The ash is the biggest, or if I get it right, the ash is the biggest.
The gray. The
gray
color.
The gray. Yeah, that's
we have orange color too. That is the biggest.
The orange color is the biggest, right?
Yes.
Yeah.
Fantastic.
Oh, I think the ash is the biggest.
That's fine.
No, we have orange, which is also ahead of the ash.
Okay, so those who are on the ward listening to the lecture, you can give it to us. You can put your video on and show the types to us. If you have Those are the private hospitals. We have the butterfly needle too. You can show them to us. Okay, my brother is what are you showing? That is
blue.
What are you showing? Blue.
That's the blue color.
So we have the blue color from Daniel. From Daniel, that's fine. Do you have other colors with you?
Currently no, please.
Okay. But on the ward, there should be different color because of different patients, different size of the veins. So the size of the vein would influence the type of cannula that you should pick. If the veins are bigger, you cannot go and pick smaller cannulas. If the child vein is very tiny, then you have to look for smaller cannulas so it can fix into the lumen without destroying or getting interstitial. Okay, needle or cannula. So that is what I've talked about. The smaller the cannula or the diameter, the slower the slower the flow rate, and the bigger the lumen, the faster the flow rate. So that is how it is. So we have needle or cannula position. Should the bevel of the needle or the cannula contact the wall of the vein, the flow of the fluid will be interrupted. Sometimes you enter the vein, you are inside the vein, but the bevel, which is the tip of the cannula, is in direct contact with the walls of the vein. And therefore, once the bevel is contacting the walls of the vein, the infusion will never flow. So you see that you pull it back small and it starts flowing. You pull the cannula small at the back and it starts flowing. That is how it is. So always make sure that the position of the needle is very, very important. Don't let the bevel. Ebenezer, Sam. The class should do what to you? You are disturbing everybody. You don't see that. Okay. So the bevel of the needle or the cannula shouldn't touch the wall of the vein. Otherwise, it will prevent the flow rate. It will not even flow. But if you push it small at the back, the infusion starts running. Then 10, we have what is called infiltration. Infiltration. Should the needle or the cannula slip out of the vein or puncture the wall of the vein, the fluid will leak into the surrounding tissues. Edema will occur. Tissue space will fill, causing the flow rate to cease. So infiltration is when you have the needle or the cannula slipping out of the vein and enter into the interstitial space. And then it starts filling the interstitial space. So the space around the needle becomes filled with fluids. So you say the infusion or there's infiltration. Infiltration has occurred, but the needle is in the interstitial space. I hope it is clear. There has been an infiltration, but the needle is in the interstitial space. And that when the fluid becomes excessively more, the pressure around that will be more than the pressure the infusion is running with. So it will stop the infusion from dripping. So the infusion will stop. When the hand becomes so much swollen with too much pressure, the infusion will not run again unless to change the veins or look for a different site. Formula for calculating the IV flow rates. We have formula for calculating the flow rates, and this always comes in examination. Whether you like it or you don't like it, you calculate, do calculations. There are two methods of calculating the flow rates. We have the number of milliliters per hour and the number of drops per minute. So the question may ask you to calculate in milliliters per hour or in number of drops per minute. If it is number of drops per minute, the formula is different. If it is the number of drops or milliliters per hour, the formula is also different. So commercial brands of intravenous equipment differ, and there are variations in the size of openings of the drip chambers and consequently in the number of drops per milliliters. Drops per mil are indicated on the container boxes of the IV infusion sets. Common risk factors are, so once you take every given set, the drops per mil is indicated on it. So you go accordingly. Some have 10 written on it, others have 15, others have 20. So 10, 15, 20 drops per mil for micro drip sets. So here we are not going to look at the micro. So we are looking at the micro drip sets, and we have drops per mil or mil per hour. The hourly rate of infusion can be calculated by dividing the total infusion volume by the total infusion time in hours. So for example, if I give you 1,000 mils, write it down. Everybody write 1,000 mils. You are using mil per hour, and the time is 8 hours. What will be the drop rate when you are giving that? What will be the drop rate? Yes, Solomon.
The answer is even on the screen. 125 mil.
125 mil per hour. So always when you are given an infusion, the amount of infusion that you are given, look at the amount in mils. Look at the amount in where? Look at the amount in where? And not in liters or in any other. Very good. So in question, you may have some questions, and the amount will be in liters. The amount will be in cc. You have to convert them into mils. And amount that you have will be the amount of infusions. Then you divide it by the total time in hours. Total time in what? Hours. Very good. And that will be the mil per hour. Fantastic. I hope there are no questions. Now, drops per minute. So calculating drops per minute. The drops per minute must be regulated to ensure that the prescribed amount of solution will be infused. Sometimes the doctor is very particular because the patient may be having some chest condition, pneumonia, some respiratory disorders, but he doesn't want the infusion to run so fast to congest the chest, cause pulmonary edema. So what you need to do is to make sure that you regulate the flow rate to suit what the doctor has recommended. So the drops per minute is calculated by the following formula. Here you have the drops per mil. So drops per mil times the amount of fluid to be infused divided by the total time of infusion in minutes. The drops should be in mils, or the amount of infusion should be in mils, times the amount of, that is the drop factor, the drop per mil, the drop factor, times the amount of fluid to be infused, also in mils, over the total time in minutes. So here, our infusion is in mils, and our time is in minutes. That gives you drops per minute. drops per minute. Okay. So before I move on, everybody take a sheet of paper and a pen. Take a sheet of paper and a pen. When you are done, let me know you are done.
We are done.
You are done? That's fine.
Sir, we are done.
Okay. Can I start the question?
Yes, please.
Okay. So you have been ordered to infuse 5 liters of normal saline. You have been ordered to infuse 5 liters of normal saline. You have been ordered to infuse 5 liters of normal saline. At 8 a.m. in the morning. At 8 a.m. in the morning. At 8 a.m. in the morning. By 6 p.m., the doctor came to review the client. By 6 p.m., the doctor came to review the client and ordered another 5 liters of Ringer's lactate. And ordered another 5 liters of Ringer's lactate. Which is to run to the next 6 a.m. in the morning. Which is to run for the next 6 a.m. in the morning. For a client who has been experiencing severe diarrhea and vomiting. Who has been experiencing severe diarrhea and vomiting for the past 3 days. Question 1. Or A. Calculate the drops per mil. Calculate. Or mil per hour of this infusion. B. Calculate a drops per minute for this infusion or for this patient. Calculate the drops per minute for this patient. Okay, if somebody has written everything, the person can read it loud for us to see if everything is fine. Yes. Yes, okay, Abigail, let's hear you.
Okay, sir. 5 liters of saline at 8 a.m. in the morning. By 6 p.m., The doctor came to review the clients and ordered another 5 liters of Ringer's lactate, which is to run till the next 6 a.m. in the morning.
Fantastic.
Of a client who has been experiencing severe diarrhea in the morning. A. Calculate the drops per meal or meal per hour. B. Calculate the drops per minute for this patient.
Okay, so for a client who has been having severe diarrhea for the past 3 days, that you did not get well for the past 3 days. So it tells you the severity of dehydration.
Okay, sir.
Okay, but the questions are intact. I hope everybody is okay with it. Yes, let me hear your hands. Yes, let me see your hands. Okay, so Abigail, your hand is up, and Asaliga, your hand is up.
Yes. The ringers, how many meals or the amount is not given?
5 liters.
No, I said the ringers, how much of it is not known?
The ringers.
Yes, please.
And I said it's 5 liters.
Oh, 5 liters. Okay, thank you.
So you take the drop factor, take the drop factor to be 10. The drop factor to be 10. The drop factor is 10. For this particular infusions, the drop factor or the cannula that you are going to deliver at 10 drops per ml. So that is the delivery factor, 10. So drop factor DF should be 10. So calculate for the ml per hour and then the drops per minute. I hope it's clear. Yes, another person. Okay, let's hear you. Yes.
Sir.
Yes.
It said the first 5 meal was given at 8 a.m.
Yes.
Then the second one was given at 6 p.m.
Yes.
To be given between 6 p.m. to 8 a.m. So my problem is the 8 a.m. order. To me, it was on hold at that. Was it on hold till the 6 p.m.?
What happens on the ward? What happens on the? We are being practical. We don't want to be more always theoretical. We want to be more practical. What happens on the ward? It was a continuous infusion, okay? And the doctor came and reviewed and saw that the way the client has become dehydrated is not going to be enough. So he added the Ringer's lactate, the 5 liters, to also run for the next 6 a.m. the next morning. Do you understand?
So if I get you, it means the first 5 liters was given between 8 a.m. to 6 p.m.
Yes.
As if I get you clear, it means the first liter was given between 8 a.m. to 6 p.m.
Yes. And at the same 6 p.m., the Ringers were added.
Okay.
I hope it's clear.
Right. Yes.
Very good. Okay, so we can move on. Okay, so example, if the order for the IV is 100 ml per hour, the formula is, okay, so the 10 drops per ml times 100 is going to be this. So that's the drops per minute. So here you have 100 mils of the infusion to run in 1 hour. So you change the hour to be 60 minutes. And therefore the drops is 10. So 10 times 100 over 60, that gives you 16.7. Okay, then that's the micro drip set. That one we said we are not so much concerned. So drip flow regulation is controlled by tightening or releasing the roller clamp, white plaster clamp, and counting the drops falling into the drip chamber. Adams, Yes.
So please, I'm sorry to pull you back a little bit. I just want to declare there's some questions under the question that you give us. Is it 3 or 2?
It's
because
2.
I have heard of it's 2.
2. The first one is the meal per hour. And then the second one is drop per minute. That's all. I just want you to use the 2 formula to
per hour and then the per hour,
then the minute.
meal per hour, and then drop.
Yes, that's all. That's all. Okay.
Thank you, sir.
So if you can also try this question, you use 4 liters to run in 24 hours. The drop factor is 15. You can also calculate this in addition to the question. So that is it. I always let you work for some time and become familiar with the calculations. Complications of intravenous therapy. Yeah, Daniel? Daniel.
I think if we are using this one, the drop rate is going to be too high. Because I'm getting like I divided the time because the first one
Daniel, let me finish with my lecture. Okay?
Okay,
yes. Sir. Complications of intravenous therapy. The complications of intravenous therapy are categorized as local, systemic. Work for your answer. Just work for your answer. We'll discuss this. Local, systemic, and mechanical. So we have local complications, we have systemic complications, we have mechanical complications. My questions are always from the ward. I give practical questions. If you are on the ward and you think you do things right, you get them. You get them. You are coming from the ward all the time. Local complications. Local complications are those that occur in and around the venipuncture site. So when you insert a cannula and any complication occurs around the venipuncture site, we are talking about local complications. So some of the local complications are 1, extravasation. So extravasations are different from infiltration. So let's look at the difference. When we talk about extravasation, which is a leaking of fluid into the tissues around the IV site, occurs when the vein wall is punctured or when the fluid is flowing into the surrounding tissues rather than into the vein, as occurs when the needle or cannula inadvertently slips out of the vein. So here, there has been extravasation. Mistakenly, the cannula or the needle slips out of the vein and starts delivering infusions into the surrounding tissues. We call it extravasation. Extravasation. Then we mentioned infiltration. Is the accumulation of fluids causing the tissue to swell, giving the area involved a puffy appearance. The skin appears white in color and may feel hard and cold to touch. The patient may feel pain and burning, and no blood returns upon when you remove the cannula. Observe when the IV container is momentarily lowered, you don't see blood coming out. All the area is occupied with fluids. 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 So you should clearly know the difference between infiltration, which is a complication of extravasation. Once the needle slips out of the vein and enters into the interstitial space, starts delivering fluids around the tissues, and that is extravasation. When it keeps on happening and the area becomes filled with fluids and that the infusion stops because the hand is swollen, the area becomes cold, looks puffy in appearance. This shows that there has been too much accumulation of, so we call it infiltration. So infiltration is a complication of extravasation. You should know that. So phlebitis, thrombophlebitis, and sclerosis. And in definition, so occurs as a result of vein irritation and inflammation, but are not typically observed in a short term. So in a short-term therapy, like we are receiving infusion to recover and go home, you don't observe phlebitis. So phlebitis doesn't occur in a short-term therapy, but it occurs in a very long-term therapy with the patient being on the ward for a week, 2, 3 weeks, and thereafter. So you can see phlebitis happening. Then we look at systemic complications. Systemic complications. What are the systemic complications? Systemic complications occur apart from the local complications. Watch for specific signs and symptoms. So once there's systemic complication, it means the infusion has been polluted by certain things and is going through circulatory system. That is systemic. So you could see signs of infection. So the patient is going to see inflammatory process and signs of chills, fever, headaches, backache, nausea, vomiting, shortness of breath, cyanosis, syncope, paralysis, shock-like state, pyogenic or fever-producing reactions include. So here, if the infusion has become infected with pathogens, so the patient may show signs of septicemia and bacteremia, resulting from the use of contaminated equipment or solutions. So once you use equipment or solutions that are infected with pathogens, the patient is going to show signs of bacteremia or septicemia, and that is very, very dangerous. Pulmonary embolism. If you run infusion faster than required drop rate, the infusion is going to run more than what the heart can drive at a time. Going to have excess fluids around the lungs. And that's what we call pulmonary. Is going to slow down the blood, let the sum of the blood becomes clots, and move the clotted blood through the veins and go in a lot of veins or at the lungs. So embolism is when a clot, or could be air, could be anything that goes to block the lungs. So the pulmonary arteries cannot exchange the deoxygenated blood for fresh oxygen. So a clot that you would have used heparin to dissolve, a clot that you would have used normal saline to dissolve at the venipuncture site, at the cannula site, you pushed in the fluids with a needle or syringe, and the syringe with the fluid pushed the clot through the circulatory system, goes through movement, circulation. Then at the pulmonary side, on the right side of the heart, through the inferior vena cava, the clot enters the right side, goes through the right atrium, enters the right ventricles. The right ventricles contract. Then the clot is ejected into the pulmonary artery, where deoxygenated blood is going to the lungs for exchange of gases. Then the clot goes through the pulmonary artery at the junction where the pulmonary artery branches to supply the right and the left lungs. That area is constricted. We call it bifurcation of the pulmonary artery. It's constricted, and this clot blocks this area so that deoxygenated blood cannot have access to fresh oxygen. This is what we describe as pulmonary embolism. So you don't have going to the lungs for exchange of gases. So if you see signs like chest pain, coughing up blood, thin sputum, shock, These are signs of pulmonary embolism. It can be air embolism when you allow so much air into the giving set or the IV tubing, and that air forms a clog and prevents blood from reaching the lungs. It's also a form of embolism. We call it air embolism. Where a given amount of air mistakenly enters the circulatory system, reaches the heart, and produces cardiac arrest. Air embolism can occur and give you cardiac arrest. The administration of up to 10 mL of air intravascularly can have serious, if not fatal, effect. So if you give 10 mL of air into the circulatory system, it can give you a serious side effect or fatal effect. Safe practice dictates the avoidance of air into circulatory system through the IV equipment. However, small bubbles of air may be tolerated by most patients, sometimes on the ward. If the amount is too small, we ignore it. But if it is up to 10 mL, serious complication can occur. To prevent air embolism, use closed system infusion sets. Ensure that the tubing drip chamber is 1/2 full at all times. The chamber that the infusion bar drops into is always 1/2. If it is full, you will not know whether the infusion is dropping or not. So always set it 1/2 full. Always the nurses, you know all this already. And remove all air from the tubing prior to connecting them to the patient cannula. So make sure that before you connect any given set to the patient's cannula, there's no air bubble. Make sure that all connections are tight so the infusion doesn't leak. Then we also have what is called catheter embolism. Sometimes when you are trying to insert this purple color catheter, the smaller catheters, it is so fragile that the tip of the catheter can break and enter into the circulatory system and go through and lodge at the point I told you. This is called catheter embolism. Okay, when a portion of the plastic cannula breaks off and flows into the circulatory system. It can be detected by exposing the body to X-rays, where I told you that that rubber catheter is made up of certain elements, silicone, and certain infrared material, which can stop radiation. So once it enters circulatory, we expose the person to X-ray, and we can know where it's lodging. Surgically, we can remove it. Pulmonary edema generally follows circulatory overload. It's just a simple circulatory overload. You are running the infusion more than what the heart can drive at a time. So you have excess fluid around the lungs, giving you pulmonary edema. Generally follows circulatory overload. Symptoms include, so when you're experiencing headache, it will definitely raise the blood pressure. So there'll be headache, there'll be hypertension, coughing because of the irritation of fluids around the lung, there'll be coughing. Dyspnea, because the fluids will drive away the air. The heart or the lungs will beat the fluid, and there will be signs of crackles. Crackles, just like you have a bucket of water, you put your hands inside and you move your hand. So those sounds you hear. And when the lungs move around fluids area with the you hear crackle sounds. That tells you that there are fluids around the lungs. And it's a bad sign, a very, very bad sign. It's a sign of pneumonia. We diagnose pneumonia with this sign. So the patient becomes restlessness because of a lack of air. During the acute phase, the infusion should be slowed to rotate to a rate that will maintain the patient IV rate. We have mechanical complications. Mechanical complications occur as a result of a change in the position of the needle in the vein. So the position of the needle can change in the vein. The height of the solution can change. The amount of solution remaining in the container when it's getting finished can affect the flow rate, can cause also then the venous spasms. Position of the patient, king tubes are all mechanical complications. Disconnected tubes, some patients can become restless or just struggle, and before you realize the cannula is disconnected from the IV tubing, and the patient may bleed if you are not careful. This patient may bleed to death if it happens. So be careful. Always make sure it is tight. Plugged air vents and plugged needles are cannulus. Management of mechanical failure centers around observation and systems. So we will not go into biases or procedures for this. Any question so far? Yes. So let me hear you with your answers. Yes. So wisdom, your question says, please, if by mistake air is pushed into, can something be done? Wisdom, if it is not up to 10 mil, fine, no problem can occur. But if it's up to 10 mil, that will be a great, it's a great complication. It's a very big complication. You can't do anything about it. Because once something gets in the circulatory system, that is it. You can't do anything about it. Yes. So let's be careful all the time. So Amwakon is saying that sir, please, it means that in extravasation there's no swelling. In extravasation, the infusion has started leaking into the interstitial spaces, so you don't see swelling there. It's just that there is fluid, or the needle has slipped into the interstitial space and fluids have started leaking around. So you don't see swelling there because the fluid is not much. But once it becomes infiltration, then the fluid has started giving the area a puffy appearance and swollen appearance. So that is it. Infiltration is a complication of extravasation. That is true. So please, what is the difference between that is coming from Inokweku? Difference between extravasation and infiltration, we have given that right now. Okay, so that is it. Okay, so so you read the rest. You manage a dislodge IV. So read the rest. You read the rest. So read the rest. Okay. So far, yes, let me hear your. Okay. So the question I gave you, I am still marking the assignment I gave you. And I'm seeing signs of copying. Some people copy directly from their friends. And if I see that, at least some sentences should change, at least some phrase or the English should change, but you can't copy verbatim. When the person does mistake, you also do a mistake. I mean, that is verbatim copying. That is wrong. So you can't copy like that. This assignment I've given you, this calculation, please, if you do that, I will just advise myself. So I don't want to see any kind of copy. If you copy from your friends, do independent work. That is what I'm looking from you. Do independent work. Somebody's hand was raised. Let me hear you. Yes. Yes. Yes, Azuma.
Sir.
Yes. Yes, I'm listening
Please,
to you.
heparin block. I'm a bit confused there. Is it a different kind of cannula or our normal cannula that we withdraw? Like that side is not clear.
Which side?
The heparin block.
Is it that we are flashing the line with it, or is another type of cannula that is having the block?
It's the syringe. I told you, if you heard me, when did you join the lecture? I said,
I joined for the beginning.
Yes, and you didn't hear me saying that we use the normal syringe on the ward to spray got it. Sometimes saline inside and lock it so that clot doesn't form around the cannula site.
Okay.
Sometimes some wards have heparin. Fine, they can dilute the heparin and put it inside, and that is okay. You can push in small, and that will prevent clot formation. So it's the normal syringe that we use. We don't have the original saline locks. Are you with me? Yes. We don't have it. Okay. Yes. Any question? Yes. 3 people hands are up. Okay. So yeah, Imoro, then Pokuya. Imoro, then Pokuya. And then Daniel. Yes. So Imoro.
Please, sir.
Yes.
Sometimes, in the ward, when you are giving the infusion, there will be air bubbles in the infusion set. So sometimes when you want to stop and splash it out, someone will tell you that, oh, you leave it and open at the cork. So when the air bubbles is coming closer, it will just pass through that cork and move out. So I don't know whether it's true or not.
Yes, that's true. When you open the cork, the air will pass out, but don't let it to be too much. If it is too much, some will definitely enter the patient. If it is something small, fine, it will just leave from the cork. But it depends upon how much air is allowed.
Okay,
sometimes if it doesn't come out, you will see it, the bubble still entering the patient's cannula. You see it. Air, you can see air when it's mixed with water, you can see it. But once it gets out, the bubbles, you don't see it again. Yes. Okay. Any questions so far? Yes. 2 people's hands were up. So that was Pokuya. Let's hear you.
Sir, please, my first question has been answered.
Yes.
The second one, at the beginning of the lectures, I heard you saying Cipro is an infusion. But when I was doing my service, some staff told me that ciprofloxacin is a drug, it's a medication, it is not an infusion. I need clarification on that, please.
What question are you asking? Don't we have
big
Cipro what are you asking? What you are saying?
At the big
Listen. What you are saying.
Okay.
Have you started working?
Yes, please.
And you are asking this question. Huh? When you are when you are doing your care plan, when you are doing your care plan, listen carefully. When you are doing your care plan, at the back of the care plan, we have other medications, and we have treatment. We have other treatment, and we have drugs or medications at the back of the care plan. So at the back of the care plan, we put all drugs the doctors have written at the treatment side or the medication side. Okay, talking about the medications, that's the first column at the back. Talking about tablet, mixture, and that is where we add infusions as part of the medications. Infusions as part of the medications. So if it is Cipro infusions, it goes there. It's part of the medications. Whatever medication you are given, if it is fragile infusion, it goes there. If it is when you are being taught, get them teach you well. All the medications that you are given goes to that part. Then we have other treatments. Other treatment, we talk about physiotherapy, blood transfusion, oxygen therapy, wound dressing. That goes to other treatment. So if you are learning, please learn it well. I don't know who taught you, but sometimes these things, so many people create confusion. That is why when you come to do BSc nursing, we want to teach you again. So those that you got them wrong, you will be getting the right information. So you go and do the right thing. So we have Cipro injections, Flagyl or metronidazole, and so forth. They all come into the medication column. Then other treatments, you maintain it there. Until if you heard it wrong, this is the right information there. All right.
Okay, thank you.
Okay. So any question? Yes, Eric.
Yes, please. Master, please, I would want to get a clarification on the question given as the question on the drop, the flow rate. The first question was saying that we should calculate the drop per mils or mils per hour. I'm not so clear. If you can
Just mil per hour. Cancel the drop. It's just mil per hour. That's all.
Mil per hour. Okay. Thank you very much, sir.
Yes. Okay. Any question? Yes. Okay. If there are no questions, I think we are done with infusion therapy. We are done, and we have come a long way. A long way. So next week, God's willing, we are going to start on a fresh system, which is the gastrointestinal system, where we are going to look at GAD, Zollinger-Ellison syndrome, and so forth. So, yes, some hands are up. Yes, Samuel.
Sir, please, when are you submitting the assignment?
The assignment I have given you right now.
Yes, please.
Do it this evening and submit. This is just some 10 minutes work. Even 10 minutes is too much. 5 minutes work. Yes.
Through the email.
Through the email. But the portal, he said there's nothing wrong with the portal. Why couldn't you submit your work to the portal system? Why?
Some of us are having some challenges with the portal.
That is where you do your MISEM. The MISEM, that is where, so learn how to do the MISEM. If you are doing the MISEM, you are going to use the portal. So I wanted you to use the portal for this particular assignment, so you become used to it.
Okay.
Next week also, you are starting the MISEM, and that is where you submit. The MISEM will not be accepted at the emails. So you submit the MISEM there, the portal. So please send the questions or the answers to the portal. If you have any challenge, contact Yusuf. He's at the IT unit. Yusuf is there to assist you. He was asking me, why didn't you call him when you said you have challenge? You should have contacted him. But none of you called him. So
we call, but he doesn't answer.
He didn't answer.
Sometimes difficult to get it.
So you test him. If he doesn't answer, probably he's busy. Test him. He will respond.
Okay, sir. Thank you.
Yes. All right. Okay. Thank you. So the questions will be submitted by the close of the day. Today you'll be having a series of lectures. So let's make it Sunday. By the close of Sunday, you should be done. Yeah. All right. Okay. So in the absence of any further questions, we have Abigail. Do you want to ask something? And then Sam Ebenezer. Yes, Abigail and Sam. You want to say anything?
So I just wanted to talk about the day of submission, but you have made it clear, so I'm okay.
Yes, okay, that's fine. All right, so thank you very much for your attention. We have still some hands up. Okay.
Yes,
sir.
Please,
yes, Adam, Emmanuel. Yes, Adam and Emmanuel, and Okay, let's hear you. What do you have to tell us?
So, Adam.
Yeah.
So I want to be, yes, sir, I want to be clear. I think assignment you are talking about now is is a fluid and is the IV infusion calculation that you just gave us.
Yes. That is what we have discussed.
So,
yes, Adam.
Thank you, sir.
Yeah.
All right, sir.
Yes, sir.
Okay,
Yeah. I want to be clear, and I'm okay.
Okay, that's fine.
Sir,
Yes.
please. I wanted to ask, when I opened the virtual class, I saw the assignments you gave us last time on it. Are we supposed to submit it through that again, or it's okay?
No, what I'm talking about is this calculation I have given you. This particular question I have given you, based on the calculations, the meal per hour, and then the drop per minute. Don't go back to the last time assignment. That one is past and gone.
Okay,
and
sir.
this,
Thank
I need
you.
it to be submitted through that portal, the Learn platform. When you do your MSM there. That is all.
Okay, sir. Thank you.
All right.
All
Okay,
right, sir.
okay, thank you. Yeah, do you have something to say?
Yeah, sir.
Okay, let's hear you.
Okay, sir. Like the virtual class, the portal. No? If we are to submit there, I think this question has to be there before we can submit.
Everybody
we
has
can
the
just
question.
go ahead and.
Okay,
But
we
please,
have to give you. I think we have to give you access, open access, and I will tell Yusuf to open it for you from now and then close it at 12 midnight tomorrow. Yes. So yes. So I will send a question to Yusuf, and Yusuf will put it there. And the time will be from now, and by tomorrow midnight it will close. Okay. Yes.
Please, if I may ask, what will be the format for the MSM, please?
The format, are you talking about whether it is calculation or what?
Or MCQs or any other? That's what I want to know.
It will be MCQs.
Oh, okay.
Yes.
Thank you, sir. Thank you very much.
All right.
Sir,
Yes.
please, are we going to solve it on a sheet and then snap it there? Or we are going to use
No, use the computer, use the laptop.
Okay.
Learn it. You are doing a BSc program. Learn how to navigate and use those. You can use
okay.
it.
Okay, sir.
All right.
Thank you.
All right.